Hi, everybody. Thank you so much for joining us today for our World Public Health. My name is Sarah Dorr, and I am the Director of Professional Development for the International Studies Association, which is based in Global Affairs at UConn. For those of you who aren't familiar with the International Studies Association, it is the largest interdisciplinary organization that's dedicated to the understanding of international, transnational, and global affairs. Today's session on public health is the second installment of our series, Thinking Globally in 2025, which looks at different issues our world is facing today from various disciplinary perspectives. And this series is co-organized by ISA, Allison Casserly of Global Affairs, and Jane Gordon from UConn's Department of Political Science. Today, I am here with Joy Elwell, who will be moderating. She is based at the University of Connecticut and is a clinical professor and director and a doctor of nursing practice program. Stephen Wine, who is at the University of Illinois, and he is the director of global medicine and the director of the Center for Global Health. And he's also a professor in the Department of Psychiatry. Fumi Showers is here from UConn. She is an assistant professor of sociology and Africana studies. And rounding us out today, we have Elzio Wunder, who is also at the University of Connecticut and who is in the Department of Pathobiology and Veterinary Science. So as you can see, we have a range of different perspectives today, and they can all offer something different when looking at public health from their various disciplines. So I am going to turn it over to Joy Elwell, who will be moderating today's discussion.
Thank you so much, Sarah, and it's such a pleasure to be here with my colleagues and our audience. I'm going to open up with our first question, and I will start with Dr. Wine, and then we'll just go around to the rest of our panel. What are the most essential elements of your research for our audience to be introduced to?
Thanks, Joy. Thanks, Sarah. Thanks to UConn, and thanks to the International Studies Association for bringing this together and for inviting me. So I work in global health, and more specifically in global mental health. And what that means is I do research to develop, implement, and evaluate mental health and psychosocial interventions that are tailored to fit the complex real-world situations where vulnerable families live. For example, we developed an HIV prevention intervention, which was delivered on a train from Dushanbe to Moscow for migrant workers. In Turkey, for Syrian refugees, we developed a family support intervention that was delivered by local NGOs. In Tajikistan, we developed a step care model for mental health that was integrated into a primary care clinic. And now in Syria, for former detainees of prison who were tortured, we're integrating a mental health psychosocial program into a medical clinic. So we face a lot of obstacles in doing this kind of work, as you can imagine. One, there's a lot of stigma about mental health and in the countries that we work. There's also very little financial investment in this work from local government, from the Ministry of Health. There is high rates of social and economic problems, which really tend to drive these mental health problems and are very difficult to address. And there's really not an existing coalition of partners, of like researchers, academics, policymakers, practitioners, who can support the development and sustainability of these kinds of interventions. So really the only way to approach this work is through partnerships, many-sided partnerships and consortiums between government and non-governmental actors, between people from low-income countries and high-income countries, multidisciplinary partnerships, and working together. So, and what does collaboration look like? Well, it looks like together choosing high priority problems to focus on, problems that matter for the people and the government of those countries. It means supporting local practices and values and relationships. It means working within, again, the real world contexts where people live and work and seek care. It means building programs that are effective and scalable within a low-income setting. It means usually doing things like task sharing, which is involving persons who are either like like lower skilled professionals or non-professionals or even peers to be the deliverers of services. And it means designing studies that are going to ask and answer the questions that policymakers have for developing interventions, like why should they invest in mental health care? Why should they invest in prevention? So those are some of the things which characterize the work that I do. I'll stop there. Thanks.
Thank you so much. So why don't we segue over to Dr. Showers? And I'm going to repeat the question for you just in case. What are the most essential elements of your research for our audience to be introduced to?
Yeah, thank you so much, Joy, and thank you to the organizers of this panel for this introduction, for this invitation. I am a sociologist by training, and my research interests lie at the intersection of studies of international migration, the sociology of health, and labor studies. My research focuses on the transnational movements of people across borders and their incorporation into the health systems of receiving nations as workers. So I'm going to just briefly talk about the two major studies that I have conducted to date. The one started from my PhD dissertation and morphed into my first book, and the second one is the other one is my ongoing second book project. So the starting point of my research, and the connecting thread between the two major projects that I'm working on, is what has been termed the crisis of care in the United States and in other wealthy advanced nations. So this so-called crisis is because of demographic factors, like the aging of the populations. And it is not just that people are aging, right, but they're aging with more chronic health conditions, instances of cognitive impairment, etc. And so these demographic trends on the one hand, and there are other social factors like the fact that family members live far apart from each other, adult children are more likely to live far away from their parents. All of this means that there's a need for care in homes. This has prompted the increased need in facilities such as nursing homes, assisted living, or other long-term care facilities. There's also the need for credentialed professionals in hospitals and other clinical settings. Now, we know that the native-born population of health professionals in many high-income countries has failed to keep up with the demand, leading to a need for cheap and potentially expendable labor pools to meet these care needs. So increasingly wealthier countries have turned to importing migrants from countries in the global south to fill these care needs. Now, there's an established literature that has looked at the global migration of health workers like doctors and nurses and other paraprofessional care workers to fill these vacancies. So my first book draws attention to the reserve of immigrant labor in the United States that is called upon to meet these care needs. So I tell in that book the story of a group of English-speaking West Africans with middle-class backgrounds who have been able to enter the U.S. healthcare market as workers in various sectors, such as in elder care, in private homes and nursing homes, disability support, and professional nursing after migration to the US. So they have entered really through legalized pathways for the most part, via family reunification, refugee or diversity provisions in immigration law. Some have opened up businesses in healthcare, capitalizing on a racialized and segmented market for care, and the labor of their immigrant communities. So some people in my research had opened up businesses, they hired other West Africans in their networks, and they catered to a largely underserved and often minority populations. How it manifests in a local context, I focus my work on the Washington, D.C. metro area, actually a global city, and I focus on immigrants in the United States. The setting, the places where migrants come from, the sending context are usually presented just as the antecedent before the big move. Secondly, in the academic and policy circles where people focused on the nexus of international migration and global health, a lot of the focus has been on the so-called brain drain, right? The exodus of health professionals from poorer nations into the labor force of advanced economies. So a lot of that literature on the brain drain talks about the loss of health services, the chronic shortages of professional care in countries with the lowest densities of healthcare workers and large global disease burdens. This sort of this brain drain framing looks at excess mortality associated with the loss of expertise and staff shortages, sometimes the loss of investment in these governments in poorer nation states or lesser developed economies whose people, right, leave, right? So in other words, governments there are subsidizing wealthier countries, right, because they train people and then they leave for these wealthier countries. But the proponents of the brain drain narrative, I and others have argued, largely draw their insights from people who have left, health professionals who have left their countries of origin and spent years working away from their homelands. We know very little, comparatively little, about the educational experiences of prospective health professionals in sending countries, and even less about how decisions of migration are made from the perspective of young people, so future health professionals. And so that's where my current research project is focused on. In particular, I look at a sending nation state, Ghana, West Africa, and the Ghana is interesting for a number of ways. I can talk about that if we have time later. But so I'm looking at young professionals, medical students in training. So while they're training to their research, I'm looking at how medical education works within that setting, so a setting in the global South. I'm looking at trying to understand medical education in situ in the countries of origin. But I'm also interested in the lives of so-called aspiring immigrants. So these students, I'm interested in how they think of their futures, including how they think about migration and whether they think about migration. So so basically, I'm asking the questions, how laypersons become medical professionals, but also how they think about their futures and whether their futures involve plans of migration. So global migration within a sending country, a setting in the global South, and sort of pivoting from this sort of receiving nation center in migration studies to looking at aspiring migration, budding health professionals in training before they leave. And I'll stop here for now. Thank you.
Thank you very much. And then we'll go to Dr. Wunder, and I will repeat the question one more time. What are the most essential elements of your research for our audience to be introduced to?
Great. Well, thank you again, Joy, for the question, and thank you everyone for the coordinators for the invitation. So, I'm a veterinarian, microbiologist, and molecular biologist by formation, and so I fortunate to work with like a zoonotic disease, which is a disease that actually affects both animals and humans, which is called leptospirosis. So leptospiras are, bacteria. Spirochetes is the same family of Borrelia and Treponema causing Lyme disease and syphilis. But the major burden of the disease is actually in populations living in poor sanitation conditions or lack of health or social inequality. For years, I was focused in the veterinary side of that disease, which has a major burden in terms of economic, including in developing countries, including the United States. But during my PhD, I moved to the northeast of Brazil to do my studies, and leptospirosis is endemic there, as it is in several other countries, especially tropical countries in Southeast Asia, in Africa. And because of population, 70% of the population lives actually urban slums, where there are open sewers, there's a lot of rats, and the disease is transmitted by the urine of reservoirs, including the rat. So people in contact with those environments actually get infected. It's a disease that can be easily treatable with antibiotics, but it has the symptoms is very similar to any other major diseases that affect those populations throughout the world. So they go to the hospital with fever, muscle pains, which are very similar, and the diagnostic is actually not very good for lepto, and actually it is a neglected disease, so people don't think about leptospirosis at first, and there's a lot of misdiagnosis, and lethality can reach out almost to 50%. So it's considered as the zoonotic with the highest mortality, morbidity in the world, and although, as I mentioned, it does have a high morbidity, mortality, the investment for the disease is very few because it is a neglected disease, a disease of the poverty. So so that is it combined my passion for this ideas of like social inequality, and I shifted all my research to be focused more in the public health, without forgetting the animal side, because I do focus in One Health prospect, which is this idea we're all connected, and lepto is a good example of that, because it's an environmentally transmitted disease. It can affect humans and animals. And so it's a connection of all those portions. So my research is very multidisciplinary. I go from like doing epidemiological studies in several countries to try to understand risk factors for the disease and why some people get sick and others don't. But I also do very much basic science research in trying to understand why the pathogen itself is causing disease. But the ultimate goal of my research is trying to identify candidates in the pathogen itself that I can use to either improve diagnostics or create vaccines. So we don't have vaccines available for humans. There are vaccines that are available for veterinary use, although they are not also very effective. So having a more effective vaccine that can be used in both animals and humans can also have this effect of like One Health perspective, where you can eliminate carriers, eliminate the contamination of the environment to the animals, at the same time protecting humans and spillover infections for that. So my, I'm a little bit feel like an outlier here, but I mean, a lot of my research is actually very based in this idea of social inequalities and diseases that are actually affecting people in situations that are not ideal in terms of health and social conditions.
I don't think you're an outlier at all. Thank you very much for that. So let me just share a little bit about the perspective of nursing and my perspective in my area of scholarly interest. So in nursing, we tend to follow two pathways in research. Discovery or new knowledge research, which is the area in which our PhD prepared nurses lead, and translational or implementation science research, which is the area in which our DNP or Doctor of Nursing Practice trained or prepared nurses lead. So I am a DNP, Doctor of Nursing Practice. I'm also a family nurse practitioner. For anybody who does not know, I will do the elevator speech. A nurse practitioner is a nurse who has gone back for advanced training at the master's and doctoral levels to provide primary and specialty health care to all populations across the lifespan, care that is cost effective and has been shown in every quality study to be cost effective as well as safe and excellent. So my area of scholarly interest is in health policy and advocacy, increasing access to healthcare for all populations, both within our own country and globally, eliminating outdated and unnecessary restrictions to nursing practice and advanced nursing practice to increase access to care, and identifying and implementing innovative solutions to healthcare disparities. And if I may, just for a moment, I'll go into a little bit to the work that I've done. As I said, my passion is health policy and improving access to healthcare. Within our own country, 27 states, and this is a good thing, 27 states, districts, territories now have full practice authority for nurse practitioners. But that means that 23 do not. So there is work to be done to improve the statutory regulations that govern everything a nurse or a nurse practitioner or a nurse anesthetist or a nurse midwife does. And so we really need to continue that work. Additionally, when we talk about globally, the global South, Eastern Europe, Asia, there are many African nations, there are many opportunities to develop the role of the advanced practice nurse. While many countries have this role now, many countries do not. There is always resistance from competing interest groups that would like to keep nursing sort of back where they think it might belong, which it does not. And so my colleagues and I have worked with the International Congress of Nursing, the American Academy of Nursing, some of these associations with the first word saying American are really global nursing associations to improve training, education, and access around the world. So with that said, I'll go on to our second question. And again, I'll go around the room. How does the globe in 2025 look through your lens in your research? And we'll start with Dr. Wine.
Thanks again, Joy. First thing I just want to say that nurses are such a great resource in the places where we work and are a very effective deliverer of mental health and psychosocial support. So I'm a big fan of nurses. So when I look at the world now, I mean, of course, I see the same kinds of risks and vulnerabilities that we've seen before, and we see some of them getting worse. There's over 120 million forcibly displaced persons around the world. 2024 was the warmest year on the planet. So we have climate-related problems. There is a known epidemic of depression globally, and depression is the #1 cause of disability from health problems in the world. An estimated 750 million people committed suicide last year. So these are major issues that we think about needing to address. And it's complicated addressing these issues and going on the principle that Elcio said that, you know, we're all so connected. Consider, for example, the problem of heat and mental health. We know that increased heat, which many countries, including parts of our own country, are subject to, is associated with increased depression, anxiety, suicide, family violence. Yet we don't really understand the mechanisms by which that works. I mean, it's at some level, it seems obvious, but at other levels, we don't really understand, and we don't understand who's the most impacted and what would be risk and protective factors that interventions could capitalize on. So we need to do rigorous scientific research to understand that. But then we also need to work with communities, with policymakers, with NGOs to kind of understand how that all meshes with their priorities and how you know, scientific findings could be translated into real world successful programs to support the most vulnerable people. I think the good news is that you know, we have the science, we have the community collaborative methods. We have the partnerships to do those kinds of studies, to do this kind of work, whether it's about heat or HIV or pandemics or forced migration or other things. But, you know, now, I mean, the question is, what do we do without the support of the US government or maybe, you know, the US people? I mean, let's gotta recognize the obvious that, you know, the US government has been the largest funder of global health in the world. And so disbanding USAID and terminating funding is devastating for the people who need those programs and for the practitioners who operate those programs. Regarding mental health and psychosocial interventions, I don't know if it's obvious to the public that so much of the prevention work that we do, whether it's in HIV or in other kinds of prevention, like say drug abuse or child protection, so much of those interventions have mental health and psychosocial components embedded within them. And so those are very vulnerable too. I think that another concern of mine is that the NIH and the Fogarty International Center is a major funder of global research, and I think there are threats being posed to those institutions. Another concern is the US government's withdrawal from cooperating with the WHO, which provides expertly driven communication, coordination, collaboration in humanitarian emergencies and is so necessary. So, you know, I mean, terminating funding also impacts not just projects which are needed by vulnerable communities, but impacts the institutions that do that, including universities here and abroad. It impacts the pipeline by which practitioners and researchers are trained, such as Fumi was talking about. But also on the research side, you know, the research that we do in low-income countries is very much accompanied by capacity building efforts in those countries. So I gravely worry about the impact on the pipeline of young researchers and young practitioners who want to build careers and, you know, help their communities in these areas. We at our medical school in Chicago have 48 global health medical students who are, you know, committed to developing expertise and working in this field. And what kind of future do we have for them without the support of the U.S. government? These are some of my concerns today going forward. Thank you.
Thank you very much. We're going to switch over to Dr. Wunder. I'm going to repeat the question. How does the globe in 2025 look through the lens in your research?
Sure. Yeah, I think, you know, going back what Dr. Wine was saying, you know, I do work with like a disease that is, you know, it's environmentally transmitted. So when you think, you know, that we have like extreme weather events happening more frequent than ever, we have like, you know, it's a disease that is more common in tropical countries, but then you have the temperature in the world actually rising everywhere. So, you know, so that puts a huge perspective in terms of like the risk of that disease itself is spreading and seeing places where we don't see before, but also like in, you know, in higher. And then you add that issues like, you know, refugee camps and people migration from the rural areas to the urban areas, increasing poverty, increasing social inequality in cities. That also put a huge perspective in terms of like diseases, not only leptospirosis, but other diseases that are, you know, that will start showing up that we don't see before. You know, and that goes into this whole aspect of like One Health that I mentioned, that the idea of all connected. So, you know, so the One Health approach is basically this idea that, you know, whenever you work with the environment or the humans and animals, you know, affects everyone, right? So, you know, it drops out of this idea, an anthropocentric idea that, you know, everything is based on the human being. So, you know, diseases are transmitted by the environment, diseases are transmitted by animals. So you can not only look at the human side of the things, in order to assess the future risks that we have to think about all those. And that's exactly what, you know, One Health, you know, fights for, is this shift of paradigm, which, you know, you don't, you know, dealing with threats, but you're actually dealing with, you know, risks, right? So you're thinking about what can happen and not what's happening right now. And you know, as Dr. Wine pointed out, I mean, when we see, you know, the lack of funding for international, you know, global health in general, or the, you know, stop of communications between organizations, either internationally or nationally. So that affects, you know, what we think about in terms of surveillance of diseases, and how you actually address the disease. You know, I think a good example in terms of like specifically for One Health, it was happening with the avian influenza right now. I mean, you see, if there's no communication between public health, you know, veterinarians, and also like wildlife conservationists, you know, you cannot deal with diseases like that. So, you know, the moment that you cut fundings, you stop communication between those agencies, and then you affect, you know, what is the outcome of that, and then eventually becomes something much worse. So, you know, so my research, you know, in general, either thinking about leptospirosis, that what I do, but, you know, in this whole aspect of like One Health in general, is that, you know, there's more than ever, we are living in a world that, you know, everything that happens is affecting us, you know, as you know, mental health, it is a great example of like One Health itself, because as Dr. Wine mentioned, you know, if you have like, you know, the high rise in temperature, or if you have like, you know, issues of like, you know, getting access to food or getting access to health, you know, all those things affect your mental health. And needs to have like the collaboration and the communication between sectors, and also investment, right, in things that ideally are diseases or situations or that, you know, you think is not going to happen. I always use the example of, you know, of course I'm biased, but I use the example of leptospirosis because, you know, like the, you know, leptospirosis was a disease that was, of course, more related to like, you know, veterinarians dealing direct with animals, or people dealing direct with animals, or some specific professions dealing with like sewers and, you know, cleaners of streets and things. But but of course, with the globalization and people traveling, so now you have like a diseases, you know, people from the United States traveling to Southeast Asia and swimming in a lake that's contaminated, coming back and get positive. So the number of cases in New York City of leptospirosis has been for the past 20 years, like 3 or 4 cases. Most of those cases have been actually imported cases, people traveling internationally, coming back and being diagnosed in the city. For the past 2 or 3 years, the number of cases simply just went up to like, I think last year we had like 26 cases of leptospirosis, and actually 90% of those cases of transmission within the city. And, you know, the reasons are, you know, rising temperature, all the floodings that we see in the city, you know, a lot of rats, right? But also social inequalities, something that is not, you know, something that we have seen in this country as much as we see, you know, in.
I think something happened to Dr. Wunder, and we will hope for his return, but I'll switch over to Dr. Showers, and I'll repeat the question again. How does the globe in 2025 look through the lens in your research?
Thank you again. And my apologies because I had a technical issue earlier. But I think I want to reiterate most of what the other 2 panelists, Dr. Wunder and Dr. Wine, have said. From my standpoint, since I deal with human mobility, international migration, and on the sort of provider side, and I deal with migration, especially south-north migration. So I would say the outlook is a bit concerning, especially as it relates to sort of immigration policies. We're beginning increasingly seeing the rise of anti-immigration agendas and policies in Europe, definitely in the United States. And this has implications, right, for the people who the people I have spent time focusing on, people who are migrants to the United States, so I mean, again, I talked about how there's sort of international medical migration, right? The migration of trained health professionals. But some of the people I unearthed in my ethnographic research, I'm spending time in the communities of these immigrant communities and sort of understanding their social worlds. Those folks actually migrated to the United States. They had prior careers and they became health professionals within the context of the United States, especially the folks who start off in the entry-level healthcare professions, nursing assistants, disability support professionals, etc., right? They were able to come to the United States through the pathways in immigration law, like the refugee provisions, for example, for many of the Africans that I encountered, or the diversity visa lottery, that provision in the 1990 Immigration Act. Now, increasingly, as those pathways become either threatened, right, with refugee, this doesn't get as much attention as the other sort of things on the immigration agenda, but the restrictions of refugee and asylum and pathways of asylum, this has implications for the folks that I'm thinking about and talking about. On the other hand, so we, again, within the frame of brain drain, countries, the sending countries in the developing world, I've had, I want to say almost a decades at this point to contend with the draining of this resource of their professionals. And some have sort of tried to address this issue in terms of working to deal with remuneration issues, right, to provide better conditions of service, to try to retain the health professionals there. So this might be a moment, right, as increasingly there's sort of this backlash on immigration from certain quarters, right? This might be a moment for the states in the sending states to also sort of think through and enhance those efforts, maybe to retain their own professionals. So I see that as a mixed bag. Finally, I will say that in terms of policy agenda, so also sort of thinking about within the context of the US where I work, any discussions and potential policy changes to the social safety nets and entitlements programs like Medicaid and Medicare, that will have implications for the crisis of care. The ability to recruit workers, because a lot of the folks who are working, in whose lives I've chronicled, are able to establish themselves as workers, as entrepreneurs in particular, because of the funding streams available through Medicaid and Medicare. And if any potential upheavals or cuts to that would have implications for providing care to the most vulnerable among us.
Thank you very much. Well, I'm going to talk for a minute or two about nursing, and then I'm going to go back to Dr. Wunder because you got cut off. In my area of scholarly interest, I see that the world is rife, or we see that the world is rife with crises, but it's also burgeoning with opportunities to fill the gaps. So just to address a couple of them, as was mentioned earlier, the climate change crisis with heat, which affects, our outdoor workers, storms, which impact our safety. Some of our military bases are based on the coasts, and that that creates a security risk when there are major storms. And many of our manufacturing plants for IV materials, medications are also located on the coasts and in the Caribbean area. And those areas that are affected by storms will impact the supply chain for that. The political climate here in this country is also of a great concern for immigrant, as Dr. Showers was mentioning, immigrant healthcare providers, such as Dr. Rasha Alawiya from Rhode Island, who was, I'm not going to say she was deported, she was not allowed to re-entry into the United States after visiting her homeland. And the nurse midwife, Maria Margarita Rojas in Texas, who was an immigrant from Peru, trained as a midwife in the United States, and was arrested in Texas for, we're not even sure, perhaps violating their very stringent abortion policies and laws there. That remains to be seen what actually happened. But so that's the doom and the gloom, but the opportunities, there's always an opportunity, and we're all very resourceful and looking for ways for workarounds. I always say that nurses are the best at fixing broken systems. It's what we do every day. But I can tell you from personal experience, in the 2009 H1N1 pandemic, I had a small practice. I was a nurse practitioner, had a small practice, and I decided one day that I would like to be a point of distribution for the vaccine, which had come out but was not readily available. So I simply wrote a letter to the New York State Department of Health and said, I would like to be a point of distribution for this vaccine. A week later, I received a letter, you'll be receiving 2,000 doses of vaccine. Not all at the same moment, but I received them in lots of several hundred at a time. And I set up programs where I worked, in the churches in the community, in the colleges in the community, in the public schools in the community, and at the end of the day, distributed 2,000 doses of vaccine, drawing patients. And I was in Westchester County, New York at the time, drawing patients from the tri-state area, New York, New Jersey, Connecticut, upstate New York, Long Island, and had nursing students administering vaccines. Very exciting opportunity. So I'd like to close my little part with saying that I think there is hope. We are facing very difficult times, but we are going to pull together and work through it. And before we go to questions and answers, I do want to give Dr. Wunder an opportunity to have closure on his area that he was discussing.
Thank you. Sorry about that. I work in an old building here in campus, and there's some drops of energy, like very common. So, well, I just want to, I was talking about, this whole issue of like social inequality, which again is like a passion for mine. But, just going back to the example in New York City and leptospirosis, I mean, most of the cases that I mentioned that happened, like 26 cases, 90% of those transmitted within the city, were caused in people dealing with like trash collection, but also homeless population. So, it just shows you the idea that, this social inequality it is becoming an issue in this country, despite, being considered a developed country. And that has been happening, in other countries as well in Europe, where, the people that are more vulnerable are also suffering more by the issue. So this idea that, I've seen everybody talking about the effects of like climate change in their mental health or diseases or even like infrastructure and everything else. So that goes back to this whole idea of One Health, where we cannot see things so simplistic in one point or the other. We have to be approaching things in a more united way between like an environment, animals, and humans as well.
Thank you very much. So now it's time for us to go to our question and answer period. And I'm going to call upon our administrator, our coordinator, to help us, to inform us on how the questions will come in.
Questions can be asked either in the Q&A feature or in the chat, whatever is easier. But since we're waiting, I think, for a few questions to come in from the audience, I wanted to follow up on a point that Dr. Wine made about the pipeline and the research pipeline and kind of what are I'm just wondering about your personal experience. Are you feeling any of these effects of it, the cuts in research funding right now, and how do you think that could affect the pipeline at the higher education level?
Yeah, I wish I had something good to say about that, but I think that a lot of people at a lot of U.S. academic medical centers, including my own in Chicago, have had grants terminated, and those not only, as I said, those not only affect that project and the PI who's doing that work, um, but I think what the public doesn't necessarily see is all the downstream consequences of that. Um, for building a workforce, building a health practice and research workforce. So the PhD student who is going to get trained in that lab, who is going to do their dissertation based on that research, is now not going to be able to work in that space. The clinicians who are going to get trained by that senior person isn't going to get that training. So we have a system of health care, which is and healthcare research, which is, as we know, flawed. But with respect to research, it's the envy of the world. And healthcare discoveries and the ability to do the translational work that Joy was talking about, that to bring discoveries into practice, that's built on so many shoulders of so many people and institutions, and that's what's at risk right now. And I'm really frightened by what are going to be the consequences. And to me, the hardest thing is to talk to young people who want to have a future in this career, and to try to be hopeful and encouraging for them to make the investment in developing themselves, getting trained, and all of that. That's the hardest. I guess on the other hand, I want to be try to be a little bit positive. I think meetings like this are great, bringing people together. We need to stand together. The worst thing would be to be isolated. We need to stand in support of our colleagues, in support of institutions, and support of practices that we know work. We need to bear witness to all the losses that are going to come as a result of terminating grants and programs. We need to do that together. So I'm not without hope that I get from my colleagues and being together in events like this. Thanks.
Thank you.
Thanks. There is a question here for Dr. Wunder. You mentioned your work in veterinary and human disease treatment and prevention. Has your work touched upon the impact of climate change on antimicrobial resistance? And to what extent have you seen these as a contributing factor to the issues related to inequality in your research?
Great question. I mean, I don't work with antimicrobial resistance. I mean, I work with a bacteria that actually is sensitive to penicillin, one of the few bacteria that's still sensitive to penicillin. So I don't necessarily do direct work with antimicrobial. I do antimicrobial resistance, as zoonotic disease is a great example of One Health. Because you have animals, and you have environment, and you have humans involved in that process. So so climate change absolutely does affect directly or indirectly. So the fact that you have more diseases coming up and more new things coming because of climate change, increase the use of antibiotics, and then because of that, you get increase also the risk for antimicrobial resistance and the surgence of super bugs. But also and that's would be indirectly, but also directly, there's several occasions where when you have goat farms, for example, there's a very common practice in pig farm. If you think like North Carolina, South Carolina, which has like a huge number of like pig farms, they have what they call like the pig pools, where like all the manure the pigs are accumulated there. And because of the increased number of like hurricanes and storms in the area, all those pools actually they flood, and all that manure, which had either antibiotics, or have like a high amount of like a bacteria that might be resistant to antibiotics commonly used in humans, is spreading the environment and affecting a lot of the times communities that are actually living around those areas. So there's a lot of studies being done of like communities around that area suffering for a high number of like diseases compared to other people in the same region. So it does have like either directly or indirectly a huge effect in terms of antimicrobial resistance, and also in terms of like inequality.
Thank you very much. So there are two questions here, and I'm going to ask the second one first to Dr. Showers. And the author writes, I was fascinated by what you said about opportunities to create businesses in ways that responded to our segregated and fragmented economy, and by what you said about your new research on the sending countries. Should we be paying to house diasporic communities, or addressing how diasporic communities can inform approaches to public health, or paying attention to that?
Absolutely. Great question. And I'm glad you asked it, Dr. Gordon, because that has been my one of the arguments that I make repeatedly, right? And especially from the vantage point of the crisis of care, which is what I spend a lot of my time thinking about. Right, we've in the sort of public health community, it's talked about as such a problem, the crisis of care and solutions to the crisis of care at the global level. And we know at the level of receiving nation states, policies, educational institutions, credentialing institutions, right? There's sort of the arguments about producing it and related to your work, Dr. Elwell, of producing nurses, to meet the so-called crisis. But an often neglected part is the actions of communities, micro communities, and here diasporic immigrant communities. And that's one of the contributions that I hope to make, which is to see how communities within and across nation states are leveraging the capital within the communities, social capital. A lot of the folks who created businesses and worked in the sectors that I talk about found work through their networks, and then information got transmitted about how to sign up for nursing school and find the credentials and work part-time. So there's a tremendous amount of resources that could be leveraged among diasporic communities as one node, right, in the intersections, right, in the various links, right, across of actors across the globe. So I agree, Dr. Gordon, great question.
So now we have we have 2 minutes. There is one more question, and prefaced by only if there is time. As many have reported, almost all elected incumbents globally, whether right or left, were voted out of power in the most recent set of elections. Many analysts focused on inflation generated in part by COVID, but I wonder if you could reflect more generally on how global depression and failures to take full stock of all of the multifaceted effects of COVID on health inequalities, and more generally, were expressed in this way. And I'm going to offer this to anybody who would like to answer.
First, I'll defer to the political scientists to analyze like why people won and lost. But I think that there's no question that the pandemic had just profound impact on people's lives and their sense of belongingness and a sense of social cohesion. And I think it empowered politicians and governments and other leaders who, who use disinformation and other kinds of strategies to, I don't know, point blame at persons such as migrants or persons of color or persons of certain religions. We know about those strategies. And I think that my concern is that that's no solution. That does more harm to, especially to democracies, and that science and public health get lost in that. We need to do a much better job in terms of advocating for health and well-being, advocating for strengthening the workforce, advocating for what are understanding the real problems and real solutions and not made up ones.
Thank you very much. Make sure I'm not muted. Thank you very much. And I think just speaking historically, we've seen that before with at the close of the Depression, the rise of anti-Semitism, anti-Asian sentiment, racism. So are we learning from history or not? But on that note, I'm going to turn this back over to our coordinators because we are at the 1 o'clock hour.
Thank you so much, everyone, for all of your comments and the audience for their questions, and Joy for moderating as well. I personally learned a lot from this session, and I do think that these are a way to kind of forward dialogue in the future, despite some of the challenges that are happening these days in the field of public health. And thank you. Thank you, everybody, for joining us.
It was a pleasure to be here. Thank you so
Thank you.
much.
All
Thank
right.
you.